let me make a comment before the question. Watching this from a historical standpoint, with which I've been inflicted by the names popping on all through this, it seems to me that we've developed the same level of frustration and sophistication over and over again. And teleology first became a mechanism by which we examined things. We found out very quickly that we could generate fallacies in hypotheses, and became very careful of it. Then we became over careful of it and started to look at things very specifically. And then, as I see this, Nick was just about leaving my lab to his own place. He decided to attack it the other way, one by one, which only a man with his amount of patience could possibly do. And so it sort of tickles me that what happened is after he's done this so meticulously, he ends up being officially stuck maybe on a more molecular level with the same thing. It's possible that all the positive things and the negative things are really identical. It's just a question of the mechanism by which they're regulated and the time. I'm done.
Thank you, Dr. Ettman. Let's see, we have a couple of hands up. Before we go on, I noticed Dr. Gabbiani is on the audience. We would like to say hello to you, sir, and give us our sincere gratitude to you for allowing us to name this webinar after you. Thank you. If you wish to say something, we would love to hear from you. Meanwhile, I would like to first hand then up was Yibin, but Yibin, you got to yield to Dr. Tagmeyer. I see his hand is up.
Absolutely, absolutely. I'm glad to.
Professor Tagmeyer, where are you?
I am here.
Very good, sir.
You can hear me.
Yes, sir.
Seeing is not so good. Well, Nick, this was amazing. Really amazing survey, and I'd just like to raise 2 points from the metabolic point of view. We are, facing in metabolism the same issue, that is what is adaptive, what is maladaptive, and is it possible to draw a line? In my work, I find it very difficult to draw a line. And I recently heard some interesting work on myofibroblast metabolism, and that has some similarities to cancer cell metabolism, actually, and that there is a glutamine addiction. It is a metabolic switch in highly proliferative cells, actually. And I was wondering what your thoughts are on this. And the other question I have about the parasites, and you probably, Mark, and we are here in Houston, remember Arif Kaku found parasites a target for receptor tyrosine kinase inhibitors, like sunitinib. And it's a consequence of parasite destruction, actually find von alpha mediated response in the cardiomyocytes. So that was my second point or question. First is adaptation versus maladaptation and glutamine addiction.
Thank you very much, Heinrich. It's great to hear from you, and these are fantastic questions. So I will start with the parasites, and you're absolutely right that they are protective functions in remodeling hearts and in this case that you mentioned with Arif's work in the context of chemotherapy-induced cardiomyopathy, I think are much more important than their fibrogenic effects. You have pericytes to support the vasculature, to prevent extravasation of proteins and inflammation, and also to control perfusion and disruptions in the pericyte network. The first, the major impact that you will have is in tissue perfusion, and if there are catastrophic events involving the relation between pericytes and endothelial cells, this has an impact on the delivery of blood and nutrients to the cardiomyocytes. So our experience also with the TGF-beta knockdown in pericytes supports this notion that there are primarily protective effects. They become fibrogenic cells. There's no doubt about this, but their main role is to stabilize the vasculature as it matures. So by knocking down TGF-beta, that is the impact that one has. And on your question regarding fibroblast metabolism and a lot of these processes and the transitions are likely to be triggered by metabolic changes in the fibroblasts. So now, what is unique, if there is something that is unique in fibroblast metabolism, is a topic that is particularly interesting to study, and the work has not been done in particular in the heart. I agree that taking lessons from cancer-associated fibroblasts would be important and helpful. It's unclear whether there is a metabolic driver for myofibroblastic conversion, or then as the scar matures, whether this dedifferentiation that one has and the loss of myofibroblast profile is again driven by some changes in metabolic pathways. It has not been studied, and I think it's a great opportunity to look at wound healing from the perspective through the lens of metabolic changes. It can provide great insights, and also it complements what we learn about metabolic effects on cardiomyocytes, because repair is so important. And if you have an intervention that affects metabolism, it's likely to be cell-specific. So understanding how this would impact the main reparative cells in the infarct would be very important.
Couldn't agree more with you, Nick. Thank you.
All right, we have Yibin followed by Lori, and hope at
Thank
the end,
you.
love to hear or at least say hello to Dr. Gabbiani on the screen. Yibin.
Thank you, Professor, and also thanks to Nick. And your journey of inquiry is so inspirational, because it was rigorous and touched upon so many really critical questions, and I learned a lot. And of course, Professor Takmir asked the most profound question I want to ask too. It's really the metabolic contribution, because you actually touch upon the mechanical aspect of the fibroblast, which has been the focus of a lot of our studies. Yet fibroblasts, as you said, is so heterogeneous. It's almost serving as the micro niche for cardiomyocytes, for macrophage, for many other cells function and angiogenesis and so forth. And I just wonder whether, number one is how the fibroblasts actually contribute during the activation in terms of the environment of metabolic change. And the second is under, let's say, under diabetes condition or other conditions, how those metabolic dysfunction contribute to the activation of fibroblasts, because that's, as you indicated, a very general or common phenomena, right, in the metabolic dysfunctional heart. Yeah, thanks.
Thank you, Gideon. It's great to see you, and thank you very much for joining and for this great questions. It's an area of great interest, the metabolic pathways in fibroblasts. So specifically looking at diabetes, I think there are important questions that have not been addressed, and we have been involved in looking at diabetic hearts and the basis for activation of fibroblasts in diabetic states. So in the models that we're using, but I'm pretty sure that this is probably true in other models as well. We're using the DBDB model. There is no myofibroblast conversion in diabetes. There is an acquisition of a matrix preserving phenotype in fibroblasts, and they produce antiproteases that may, and also cross-linking enzymes. So there is an increase, a gradual increase in matrix content, and a gradual decrease in solubility, more cross-linking of collagens that contributes probably to diastolic dysfunction. So it's a unique change, which is it driven by effects of other cell types in the myocardium? It's possible. Is it driven by the primary metabolic changes that you have in the diabetes? We have suggestions for effects. We have data supporting a role of TGF-beta signaling, which is also activated in diabetes in many tissues, in part because TGF-beta receptors their levels are increased by high glucose levels. But we also have evidence for interactions between the insulin receptor system and the TGF-beta cascade. So this is an area of high interest that we are currently exploring. We have not, and this is due to the incredible amount of expertise and both conceptual and technical that is required to do good quality metabolic studies. I mean, Heinrich is an expert on this, has been doing this for so many years, but our experience with metabolism is quite limited. So we have not yet expanded our work into looking specific aspects of fibroblast metabolism, but I think that's where the answer will be for many of the questions that we're dealing with. So there is this very interesting and unique profile of activation of diabetic fibroblasts, which likely that is not limited to cardiac fibroblasts, but would involve fibroblasts in the kidney and in other organs as well. I mean, some are more susceptible to fibrosis than others, but at least in the heart and the kidney, there is an element of fibrosis that is prominent in the pathology of diabetic complications. And it's likely that the link is a metabolically related link. What we have at least discovered is that there is the component that relates to glucose effects and utilization and insulin signaling. But I'm sure there is a lot more that could be learned in this direction.
Beautiful. I would love to interact more. Yes.
Final question by distinguished Laurie, Dr. Laurie Kirschenbaum.
Oh my goodness, you're so kind. First of all, I have a comment and then I have a question. Actually, two comments. First off, it's so nice to see Dr. Entman. Mark, it's wonderful to see you in person, and I'm glad that you were able to join the program this morning. And the other thing that I found very observational, this is the scientist now, the observation, is how many great people came out of Texas. Look at what's come out of Texas. We have Mark and AJ and Nick and Yibin and myself and many others. And of course, Heinrich is here. So anyway, it's really great to see the connection. We're all family in some way. And it's really great. I think standing on the shoulders of giants make all the difference. And Mark, I think you've done a tremendous job in moving this field. And of course, Nick taking it to the next level. Outstanding talk. What I wanted to ask you is, everybody has been talking about blocking fibrosis. And I think your talk was very profound, how many different cell types can morph or transition or differentiate, if you want, into fibroblasts, myofibroblasts. I'm curious to know how much, if anything, of the fibrosis is actually reversible. You know, we talk about blocking it, but I'm wondering, once it's in place, I recognize it's like cement. I remember a talk by Carl Weber talking about the tensile strength of the collagen fibrils and how difficult it is for obviously the heart to contract and relax. But, you know, are there inhibitors, you know, proteases or, you know, genetic mechanisms that you can actually block it or reverse it once it's actually ensued?
Laurie, first, it's great to see you, and thank you very much for joining. It's like a Texas reunion, a Houston reunion here. It's fantastic to see you, and this is a great question and particularly relevant in the clinic. So a lot of what I'm going to say is based on speculation because there aren't data. So a major obstacle here is that you would like to have a model of resolution of fibrosis where you can study how these cells change their phenotype and may resolve fibrosis to some extent. And this is a bit of a challenge. So enloading models could do that, but then you have to assume that the effects exist. You cannot serially study the fibrotic process and then its resolution, but you need to have a protocol that examines different animals, which is a bit of a limitation. But it's a direction that we're moving into, as we would like to identify clusters, subpopulations, phenotypes of cells, immune cells, and fibroblasts that may have a resolving phenotype, which should be quite unique because, you know, they should degrade matrix, but without creating inflammation, so which is very difficult to visualize. So, you know, when you have degradation of matrix early after infarction or after injury, there are a lot of matrix fragments which are generated that induce inflammation everywhere. So that does not happen when you have successful resolution. So to your question, whether you can have a successful resolution of fibrosis, intuitively, if you have a formed scar in the context of infarction, this would be an impossibility because you would need to replace the scar with cardiomyocytes, and currently we don't have a regenerative approach. So in that case, the resolution of fibrosis should be coupled with an approach to regenerate the myocardium, which is currently lacking. So we limit this discussion to the interstitial fibrosis that one has with pressure overload and an attempt perhaps to resolve fibrosis in this context. The descriptive evidence that is available and the also intuition suggests that the more cross-linked matrix you have, the less likely it is that this tissue will actually be, that this fibrosis will be reversible. So advanced chronic fibrotic lesions, they are very unlikely to be reversible. On the other hand, earlier lesions, they could be reversible by reducing numbers of activated fibroblasts or by decreasing their state of activation, and possibly also by replacing a matrix environment that may be conducive to progression of fibrosis with a more stable, healthy, heart-like matrix environment that presumably the quiescent fibroblast would support. So I think that's a reasonable goal, and the key question to answer would be whether there are some subsets of leukocytes or phenotypes of leukocytes and the phenotypes of fibroblasts as well that cooperate to complete these resolution process in a way that does not induce inflammation, and how this differ from the cells, these angry, aggressive cells that produce a lot of proteases that you have early after infarction, which are also matrix degrading. I think that's a fascinating question that to be pursued. The tools are, the models are a bit difficult and problematic in terms of having resolution of fibrosis models, but it is feasible and I think a very attractive and interesting direction. So therapeutically, the earlier it is, the more likely that one would have success. late lesions, and that comes also from the LVAD experience to some extent, and the recovery effects, which of course involve cardiomyocytes as well, but they involve to some extent the matrix recovery is more likely when the fibrotic lesions are less advanced, less extensive, and containing less cross-linked collagen.